Hi there, my name is Shannon Nixon. I'm a nurse practitioner. I work at Princess Margaret Cancer Center in the Malignant Hematology program. Today, we're going to review a video capsule around managing patients with B-cell malignancies on Bruton's tyrosine kinase inhibitors. This was a video capsule that was based on a publication recently for considerations for nurses and pharmacists in managing these patients. So just a bit of background. Treatment for indolent B-cell non-Hodgkin's lymphoma and CLL has shifted over the last 1 to 2 decades with the introduction of targeted agents. BTKs, or Bruton's tyrosine kinase inhibitors, include ibrutinib, acalabrutinib, and zanubrutinib. They've become attractive drug options. Firstly, they've received Health Canada indications for several non-Hodgkin's lymphoma subtypes and CLL. They've been shown to have superior efficacy and a favorable toxicity profile compared to traditional chemoimmunotherapy, with lower rates of hematological toxicity and infection. They do have a unique and well-tolerated safety profile, and we'll go through that a little bit more throughout this presentation. So Bruton's tyrosine kinase is a member of the TEC family of protein kinases, which play a role in signal transduction downstream of the B-cell receptor. Bruton's tyrosine kinase inhibitors function by forming irreversible covalent bonds with the C481 residue in the ATP binding domain of BTK. And this inactivates the kinase function. In 2014, ibrutinib was the first BTK inhibitor to gain Health Canada approval. Since then, ibrutinib has received several other indications in CLL, as well as for marginal zone lymphoma, mantle cell lymphoma, and Waldenström's macroglobulinemia. Due to the off-target side effects of ibrutinib, more selective second-generation BTKis, such as acalabrutinib and zanubrutinib, were developed. Better selectivity translates into better safety profile. Second-generation BTKis have received Health Canada indications in some of these lymphoma subtypes. Acalabrutinib was first approved in 2019, and zanubrutinib has then been approved since 2021. BTKis have varying selectivity for BTK and interactions with off-target kinases, leading to differences in safety profiles. We think that better selectivity of acalabrutinib and zanubrutinib has translated into these improved safety outcomes. In head-to-head trials, acalabrutinib and zanubrutinib decreased adverse events, particularly atrial fibrillation, and reduced rate of discontinuation. International guidelines recommend the use of next-generation BTKs owing to ibrutinib's worse toxicity profile and black box warning for sudden cardiac death, which we'll talk about again a little bit later. So since BTKs are given orally until progression, prevention and management of the adverse events are crucial for optimal patient outcomes. As nurses and pharmacists caring for patients on BTKis, it is important to understand the drug dosing, the co-administration, and the adverse event management. So this presentation is going to summarize that recently published paper on the management of patients on these drugs. So this chart goes through the indications and Health Canada approvals for the 3 BTK inhibitors available. As you can see, patients who have received at least one prior line of therapy can receive BTKis for mantle cell lymphoma and marginal zone lymphoma. In CLL and Waldenström's, BTKis are approved for upfront use as well as in the relapsed setting. This is the paper that was published on how we manage patients with indolent B-cell malignancies, practical considerations for nurses and pharmacists. The dosing for each BTK inhibitor was chosen based on the optimal BTK occupancy, which is greater than 95%. as the phase 1 dose escalation studies did not find any dose-limiting toxicities. While ibrutinib is recommended as a once-daily dose until disease progression, acalabrutinib is given at recommended dose of 100 milligrams BID. This dosing produced superior BTK occupancy compared to the once-daily dosing for this drug in particular. Zanubrutinib, 160 milligrams BID, was established as the recommended phase 2 occupancy in lymph nodes. However, it is approved as either a once-daily or BID dosing, since both doses can achieve the same BTK occupancy of greater than 95%, with no difference in efficacy or safety. As only unbound drug is considered to elicit a pharmacological response, a paper published by Tam and colleagues explored the kinetics of unbound drug in the plasma over 24 hours for the 3 different BTK inhibitors at their highest recommended daily dosing. As you can see here, clinically, higher drug concentration ratios achieved at a tolerable dose would be expected to lead to more sustained BTK inhibition. Now we'll talk about the co-administration considerations. BTK inhibitors are metabolized in the liver, primarily by the CYP3A enzymes, which has implications for drug co-administration. Although it is suggested to avoid the administration of strong CYP3A inhibitors with ibrutinib and acalabrutinib, a reduced dose of zanubrutinib may be given with strong CYP3A inhibitors. For the strong CYP3A inducers, BTKs should not be given at all. It may reduce the BTK inhibitor exposure. Some examples of a CYP3A inducer are things like rifampin or carbamazepine. We also know that the co-administration of PPIs is not recommended in acalabrutinib. With the current capsule formulation of acalabrutinib that is available in Canada, the solubility decreases with increasing pH. So we suggest patients don't use PPIs at all while on this drug. We know that antacids or histamine blockers can be considered, but we suggest if these drugs are used that we give them 2 hours before the dosing of acalabrutinib. All BTK inhibitors are associated with increased risk of bleeding. Therefore, we suggest avoiding aspirin, anti-inflammatories, anticoagulants, or any supplements that would increase the risk of bleeding, such as fish oil or flaxseed. When it comes to kidney and hepatic impairment, BTK inhibitors do not appear to impact kidney function, so no dose adjustments are needed for these patients. However, for hepatic impairment, the product monograph for ibrutinib recommends a reduced dose for mild hepatic impairment and avoiding with moderate or severe hepatic impairment. For acalabrutinib and zanubrutinib, the indications are slightly different. Patients with mild and moderate hepatic impairment may receive therapy with dose modifications. Management of BTKi-related adverse events. The effects of adverse events on patients taking BTK inhibitors can range from minor nuisance to significantly impacting quality of life and daily activities. They can also range from mild in severity to potentially life-threatening. The common toxicities that we'll go over include atrial fibrillation, arthralgias, infections, diarrhea, hypertension, and bleeding. And then additional, less common toxicities include skin changes, fatigue, ventricular arrhythmias, and cytopenias. Adverse events that occur frequently at a low grade with all BTK inhibitors include diarrhea, rash, headache, arthralgias, and fatigue. Although these are usually not life-threatening, they can distress patients and can frequently lead to treatment discontinuation. Although some adverse events may occur at a lower frequency with second-generation BTK inhibitors, they can still occur. So we need appropriate prevention, monitoring, and management. The first adverse event we're going to talk about is diarrhea, which has the highest prevalence in the first year and then tends to be stable or decrease thereafter. Diarrhea is generally mild, grade 1 or 2, which can be associated with about 4 to 6 stools per day and may be accompanied by abdominal cramping. It occurs in up to half of patients receiving ibrutinib and a bit of a lower frequency for the second generation BTKs. We think that it might be due to the off-target activity on the EGFR. At the bottom of this slide, you'll see a table around the management of diarrhea. Usually grade 1 or 2 diarrhea can resolve in 1 to 2 weeks without dose modifications. However, with grade 3 or higher, the BTK inhibitors should be paused and reinitiated at the same or reduced dose if severe diarrhea recurs. Some of the general management associated with diarrhea is the BRAT diet. Before initiating any sort of nutritional interventions, as nurses and pharmacists, we really want to ensure that the diarrhea is not associated with any other common pathogen like C. difficile. Obviously, if the diarrhea is associated with abdominal discomfort, we want to consider a CT or X-ray to rule out any colitis or overflow diarrhea. Once those major concerns are ruled out, we can talk to patients around increasing fluid intake, eating small, frequent meals, low fiber, high calorie foods, and management of any sort of complications such as hemorrhoids or perirectal complications. Next, we'll talk about fatigue, which is the highest prevalence in the first year, and generally stable thereafter. There's similar rates of fatigue of any grade reported for BTKs. There's a higher rate of grade 3 fatigue in the acalabrutinib compared to ibrutinib. Most common symptom reported at diagnosis presents as tiredness, impairs activities of daily living or quality of life. As we know, all of these things are common in patients with cancer associated with fatigue, such as decreased concentration or attention, sleep disturbance, decreased motivation, or interest in usual activities. It can be challenging to manage. The etiology is not well understood. But we think that the fatigue is not only related to the BTK inhibitor itself, but likely also as a response of the underlying disease. There's insufficient evidence to support management using pharmacological intervention. However, non-pharmacological interventions are definitely recommended. We definitely suggest physical activity such as walking or yoga, sleep hygiene, and that sort of thing. Headaches have the highest prevalence in the first 3 months, and then a drastic decrease thereafter. It commonly occurs with acalabrutinib and less commonly with ibrutinib and zanubrutinib. Dose modifications are not usually needed, as the headaches usually resolve after the first few months with conservative management. We suggest patients take acetaminophen and not anti-inflammatories, given the increased risk of bleeding associated with BTK inhibitors. And we also suggest caffeine, and that may help. Of course, any of our hematology patients who present with a headache in the setting of thrombocytopenia, or if they're on anticoagulation, if they've fallen or had any sort of trauma, should be investigated to rule out an alternate etiology, as we cannot assume that the BTK inhibitors are the ones causing the headaches. Next, we'll talk about arthralgias. Although some of the other AEs get better over time, we know that the prevalence is generally stable over time in relation to arthralgias. Adverse effects affecting the musculoskeletal system, such as joint pain, muscle spasms, are common in patients taking BTK inhibitors. The rates of arthralgias were similar for zanubrutinib and ibrutinib, with a slightly decreased incidence for acalabrutinib. Muscle spasms have been reported more frequently with ibrutinib compared to the second generation BTKs. Arthralgias and myalgias occur within the first few months, and mild cases resolve within a few months without dose modifications. If it's persistent and impacts their daily activities and quality of life, a dose delay may be necessary. They suggest a dose delay of about a week, followed by a dose reduction. And other sort of conservative measures can be used, such as pain relievers, again, avoiding anti-inflammatory agents, but mild stretching, strengthening, and exercises, hot and cold compresses. Ensure we're checking the electrolyte levels as another contributor, and supplements for MSK pain and spasms may also be helpful. Now let's talk about rash. Rash occurrence may be partly explained by off-target inhibition of EGFR. There's several types of dermatologic events which can occur. Mild petechial rashes are things associated with interference of platelet function. We'll talk about that in a separate slide. But the ones that are more bothersome for patients tend to be these pruritic rashes, acne-like rashes, or eczema-like rashes. Most of them are mild and resolve within a month without dose modifications. Use a temporary pause for grade 3 rashes, which cover more than 30% of the body surface and can impact self-care activities of daily living. Of course, we want to monitor for signs of severe rashes. So if this is associated with any fever, facial swelling, any sort of pustules, lymphadenopathy, any lab abnormalities, that needs additional investigation. But generally, rashes can be managed with things like topical corticosteroids, antihistamines, cold compresses, and that sort of management. Nail changes include brittleness, separation from the nail bed, ridging, depressions, pitting, and splintering. We all know about Bowes lines that occur from chemotherapy with the very distinct ridges on the nail beds, which is very similar and can come from the BTK inhibitors. They can occur in approximately 60% of patients on BTK treatment. It is not a reason to stop therapy, and we suggest conservative measures such as trimming the nails regularly, topical ointments, using sort of a clear nail polish is always a good idea to help strengthen the nails and prevent breakage. Other AEs associated with BTK inhibitor therapy, such as atrial fibrillation, hypertension, hemorrhage, cytopenias, and infection, require immediate intervention and have the potential for life-threatening consequences. First, we'll talk about atrial fibrillation. The rate of new atrial fibrillation events generally remains stable over the course of BTKi therapy. Potential risk factors include existing cardiac comorbidities, older age, being male, and challenges with the left atrial volume. Unfortunately, if atrial fibrillation occurs as a result of BTKi inhibitors, this is one of the most common reasons for patients to stop therapy. If it does happen, you want to assess the individual's stroke and bleeding risk and consult with specialists as needed. If atrial fibrillation occurs, anticoagulations are not generally recommended given the bleeding risk. So evaluation with a CHAD score can help determine the severity and necessity for anticoagulation. So a low CHAD score of 0 to 1 perhaps is not necessary to have anticoagulation. Additional considerations for anticoagulants are that many are the CYP3A inhibitors, which interact with the BTK inhibitors. We know that newer anticoagulant agents that inhibit factor XA, such as apixaban or rivaroxaban, are preferred, as even though these are the CYP3A4 substrates, they are not expected to have a clinically meaningful increase in plasma levels when given concurrently with BTKis. And again, rate controlling strategies are typically used for atrial fibrillation, with a preference for the beta blockers as first-line therapy. Monitoring patients for atrial fibrillation involves a lot of education and asking patients around whether they have signs of arrhythmia, such as heart racing, fluttering, pounding, shortness of breath, faintness, dizziness, or are they easily tired? There are rare incidences of ventricular arrhythmias, tachycardia, and sudden deaths reported with BTKis. Ibrutinib has been reported with the largest number of sudden cardiac deaths and has led to a black box warning on their product monograph. Case reports and retrospective analyses suggest that atrial fibrillation history is linked to higher ventricular arrhythmia risk with ibrutinib. Now we'll talk about hypertension. This one, instead of the risk decreasing over time, it actually increases over time. 78% of patients receiving ibrutinib had been reported to have hypertension in real-world studies, whereas 49% of patients receiving acalabrutinib are having new or worsening hypertension. So very important as nurses and pharmacists to monitor blood pressures and to teach patients to monitor blood pressures at home. Often when patients are on BTKis, we're only seeing our patients either virtually or perhaps only in the clinic once a month or once every 3 months if they're stable. And so because the incidence of new onset hypertension increases over the course of treatment, we really need to be cognizant of this adverse effect. If hypertension occurs, it can be effectively managed with antihypertensive agents. So this is generally not a reason to stop the BTK inhibitor or consider dose modifications. Now let's talk about hemorrhage. In up to 40% of patients on BTKi therapy, minor bleeding can occur. It usually occurs within the first year, but can occur at any time over the course of therapy. When we talk about minor bleeding, we think about mild petechial type rashes, bruising, and skin changes. We don't think this is necessarily related to the platelet count itself, but perhaps related to the platelet dysfunction caused by the on-target inhibition of BTK and off-target inhibition of TEC and SRC kinases. We also know that if bruising and petechial rash is present, it's not necessarily a predictor of major hemorrhage. So that can be important to share with patients. And it can resolve spontaneously without intervention. Of course, major bleeding can occur, but much less commonly. It only occurs in about 5% of patients. We want to encourage our patients to understand that they are at risk for bleeding and to watch for things like bleeding in the urine, the mouth, nose, stool, and that sort of thing. We want to ensure that they're not on any other drugs that can increase their risk of bleeding, such as anti-inflammatory agents or anticoagulants. As well, if somebody's going for a surgical procedure or intervention, we want to ensure that their BTK inhibitor is paused approximately 3 to 7 days before and after the procedure, depending on the risk of bleeding associated with the procedure, of course. Now we'll talk about the cytopenias associated with BTKs. Hematological toxicity commonly occurs both from complications of the disease itself and as a side effect of therapy. Patients can be educated on the importance of routine blood tests to monitor blood cell counts, usually monthly until the counts are stable and every 3 months thereafter. We would consider supportive care with things like G-CSF or Grastafil for patients with grade 3 neutropenia. For any grade 3-4 neutropenia and thrombocytopenia that is persistent or is associated with significant bleeding, fever, or infection, they follow the dose modifications outlined in the product monograph. I won't go into this in any real detail. However, you can see here that for the first adverse reaction occurrence of cytopenias, we would pause until less than grade 1 and then resume the starting dose. Whereas a second and third reaction occurrence, we would recommend dose modifications. Patients treated with BTKis are at increased risk of infection due to therapy and the biology of the disease itself. Of course, opportunistic infections are a particular concern and not necessarily related to neutropenia, but also related to abnormal functioning of the immunoglobulins, lymphocytes, and other immune factors. So this makes patients at risk for things like fungal infections with Aspergillus, and also things like pneumocystis, pneumonia, or PJP. A lot of our patients are also on steroid therapy, so that comes into play. We want to educate our patients to notify the clinic upon signs of infection. And of course, management of febrile neutropenia if appropriate. In terms of preventative measures, we suggest patients are up to date with their non-live vaccines. Prophylactic therapies, usually we would consider prophylaxis with antibacterials, antivirals, and antifungals. Antibacterials are not necessarily recommended. Antifungals are also not necessarily recommended, given the interaction with a lot of the azole medications and BTKi inhibitors. But we do certainly recommend prophylactic antiviral therapy with things like valacyclovir or acyclovir to prevent the incidence of HSV or zoster. BTKis can induce hepatotoxicity, possibly through reactive products of drug metabolism. Baseline hepatic impairment may impact liver metabolism, increasing the plasma levels of BTKis, thus inducing further damage. And importantly, we need to understand that hepatic impairment can lead to coagulopathy, which then adds to bleeding risk. So very important to monitor these patients regularly. And if the hepatotoxicity is suspected, the drugs should be paused and then investigated. Secondary primary malignancies following the BTKi inhibitors range anywhere from 3 to 9%, with an increased risk noted for things like lung cancer, melanoma, bladder cancer, Merkel cell carcinoma, and salivary gland cancers. I don't think we know enough about this yet, and longer follow-up is needed. This slide shows that switching to second-generation BTKis following discontinuation of ibrutinib due to the adverse event toxicity does not result in the reoccurrence of the adverse event. So in summary, BTKis are effective in numerous B-cell malignancies with favorable but unique safety profiles. Monitoring and management of BTKi-related adverse events and potential drug interactions lead to optimized outcomes and quality of life, and keeping patients on therapy. Notable adverse events include rash, diarrhea, the MSK events, cardiovascular events, which are rare but serious, and bleeding. As BTKi therapy continues to advance, it's important for nurses and pharmacists to understand the varying safety profiles and reevaluate optimal patient management approaches moving forward. Thank you very much for joining today.